Hello and welcome to another talk brought to you by physicaltherapycontinuingeducation.org. On the phone today we have Dr Stuart McGill. Dr McGill is Professor of Spine Biomechanics at the University of Waterloo. He is also the Director of the Spine Biomechanic Laboratory. His advice is often sought by governments, corporations, legal experts and elite athletes. He is also a highly published researcher, author and noted public speaker. Dr McGill, welcome to the line today.
Yeah, good morning, Sasha.
Fantastic. Well, so glad to get you on today. We want to definitely pick your brain about some of your work regarding the spine. But before we get into that, could you just give us a little information about your background?
All right. Well, I am a professor. I got my PhD, I hate to even say how many years ago now, in spine biomechanics. And obviously trained as a scientist. And then, maybe about 25 years ago, I'd be presenting at a neurological meeting or an orthopedic meeting or a manual medicine meeting, and some docs would say, would you see a patient for us? What you just showed us scientifically pertains, we think, to this difficult patient, and would you see the patient for us? And I would say, well, no, I'm not a clinician.
Right.
And slowly they would talk me into it and give me a bit more confidence. So I started to see patients, realizing that I had not a formal clinical bias on these things, and I would just go with a very scientific, almost my assessment of them was almost an experiment, provoking them, trying to find what caused their pain, motions, postures, and loads that caused their pain. Then I would try another intervention to see if I could take their pain away. And this whole approach just mushroomed, I guess, and now, as you probably know, patients, I don't see the average bad back from our area. Every patient I see flies in from somewhere around the world. And,
wow.
I get asked to do clinical courses, as you know, or I might be invited in by a med school. Would you see 3 or 4 patients in front of 100 of our staff and medical students, and I'll go in and do that. And they usually say, well, that's a different perspective.
Now, I know at the University of Washington you've got probably a unique setup. Could you just describe that for us?
Yeah, we're actually at University of Waterloo.
Oh, Waterloo, sorry.
Yeah, but that's okay. We have, yes, it is very unique in the world in that we have 2 laboratories and a clinic, and 2 very diverse laboratories all under one roof. The first one is a spine tissue laboratory where we take spines, both cadaveric and animal spines, and create the injuries on the spines so we know exactly what mechanical insult led to very specific types of tissue damage. We learn about thresholds and mechanisms and whatnot, and we then are able to be quite clear as to what the specific cause of damage is when we see it, and we're very clear in what to avoid with that particular patient. They certainly don't want to exacerbate or replicate the original injury scenario, and off they go from there. The second lab is an entirely different instrumentation. It's set up for real people, not dead people.
Right.
And we measure their motor control systems through electromyography, how their brain is organizing their muscles to activate around their spine and hips, etc. And we're able to evaluate whether it's a very efficient scheme they're using or it causes them to be unstable, for example, how much load they're imposing on the various tissues, and is that a good idea or is there a better way? And the third element is the clinic, where we actually see people. We do perform experiments on them. So sometimes our treatments are experimental. But that's the third element that tells us if what we've come up with works or not.
Right.
So it's the essential third element.
Yeah, fantastic. If we switch gears here to more assessment, can you describe how you assess patients?
It's probably not what people would expect as standard fare. If I'm really needing to sort out a back, it will take me about 3 hours. And it begins with an interview. I ask the patient about their pain patterns, what they perceive as causing the pain in terms of activities and motions, postures, and loads. What can they do without getting pain when they roll over in bed, for example? Do they get sharp pains? That would be an indication of unloaded spine instability, for example. So we have a set of questions like that, probing them to try and understand the nature of their pain. And also other things like what do they currently do for their back, what therapies have they tried in the past that haven't worked, and this kind of thing. Then we watch their movement habits, and this is huge. We watch from the very second we enter the waiting room how they're sitting. Patients often sit in a way that causes their back pain. It's almost paradoxical. If someone is flexion intolerant, they sit in flexion. If they're extension intolerant, they almost always sit in extension. So that's a huge clue. Simply watching them get out of the chair, if you know the signs, you'll see if they have gluteal deficiency and are hamstring dominant, for example, which is a very common pattern of those who've had chronic pain. And then we watch them walk. And then if they are, say, an electrician, we might be watching them bend over, get down to the floor, get back up again, all this kind of thing. If they're a sportsman or an athlete, we will ask them to perform some of the athletic moves that are both painless and painful. So these are signature movement patterns or habits that quite often, if they are not changed, will thwart the recovery of the patient.
Fantastic. And your website, BackFit Pro, is that correct?
Yeah, www.backfitpro.com. That's BACKFITPRO. It's exactly how it sounds.
Very good. Well, Dr. McGill, I'd like to thank you for coming on the line today. Very much appreciate it.
My pleasure.
Excellent.
Have a great day.
Thank you very much. And, well, thank you for listening. We hope you enjoyed this interview. For more great interviews, please visit us at physicaltherapycontinuingeducation.org. That's physicaltherapycontinuingeducation.org. Thank you.